Hypoglycemia. Key points. Hypoglycemia is a blood glucose level, BGL, low enough to cause signs and/or symptoms of impaired brain function and neurogenic response, generally BGL and LT 3.3 mol/L. Infants with BGL and LT 2.6 mol/L and risk factors are at risk of acute and long-term neurological sequelae. Altered conscious state or seizures warrant prompt BGL assessment and management with a bolus of 4-10% dextrose, ml/kg, or IM glucagon. A venous blood gas and other diagnostic blood tests are important to identify an underlying cause but should not delay. Management. Background. Hypoglycemia is a BGL low enough to cause signs and/or symptoms of impaired brain function and neurogenic response. Generally BGL and LT 3.3 mol/L. In neonates and LT 48 HRS old, there is a lack of consensus on what constitutes normal BGL, however. BGL and LT 2.6 warrants immediate intervention. Prolonged or recurrent hypoglycemia, especially with clinical features, can cause long-term neurological damage or death. Age at presentation can indicate the underlying case. Neonate and LT 48 to 72 HRS. PREM, IUGR, perinatal asphyxia, hypothermia, sepsis, RESP distress, diabetic mother, macrosomia. Syndrome, e.g. Beckwith-Wiedemann, pancreatic dysfunction. Neonate 2YRS. Congenital hyperinsulinism, most common cause of persistent hypoglycemia and LT2YRS, inborn errors. Of metabolism, congenital hormone deficiencies, e.g. growth hormone deficiency. Child. Accelerated starvation, previously known as ketotic hypoglycemia, hypopituitarism, hormone deficiency. Adolescent. Insulinoma, adrenal insufficiency, eating disorder. All ages. Other illness, e.g. sepsis, congenital heart disease, tumor, adrenal insufficiency. Accelerated starvation is a diagnosis of exclusion. It requires a history of a prolonged fast, usually precipitated by a mild illness. With low BGL in association with ketonuria and/or ketonemia and normalization of BGL upon feeding. Assessment. Red flag features in red. History. Symptoms of hypoglycemia. Palpitations, tremor. Anxiety, sweating. Hunger, paresthesia. Severe hypoglycemia. Lethargy, irritability, uncharacteristic behavior, hypothermia, confusion, coma, seizures. Neonate and LT 48 HRS. Apnoea, hypotonia, jitteriness, poor feeding, high-pitched cry. Dietary history, fasting/illness and relationship to food. Milk products, galactosemia. Fructose e.g. juices, hereditary fructose intolerance. Protein, amino acid or organic acid disorders. History of toxin ingestion in toddlers or young children. Consider accidental ingestion of alcohol, oral hypoglycemic agents. Sulfonylureas, aspirin, beta blockers, or toxins. Increased glucose requirements, e.g. sepsis, shock, tumors, trauma. Past history. Neonatal history of hypoglycemia. Episode suggestive of hypoglycemia, e.g. undiagnosed seizure disorder. Previous gastric surgery, fundoplication, postprandial hypoglycemia. Family history. Consanguinity. Unexplained infant deaths, hormonal deficiencies and hyperinsulinism. Examination. Altered conscious state. And seizures, fever or hypothermia. Finding related to underlying diagnosis. Hepatomegaly and/or hypotonia, inborn error of metabolism. Poor growth and nutrition. Dysmorphic syndrome. Management. First presentation or severe hypoglycemia should be investigated. Infants and LT48 HRS of age who respond appropriately to enteral feeds are unlikely to need extensive investigations. A capillary glucometer reading is unreliable at low readings, hence it is important to confirm that true, laboratory, BGL is and LT 2.6 mol/L. Investigations. Venous/capillary blood gas. Diagnostic blood tests during the period of hypoglycemia, either at the initial presentation or during an elective fast, prior to management. Plasma glucose, ketones, beta-hydroxybutyrate, free fatty acids, insulin and C-peptide, lactate, ammonia, cortisol, carnitine/acylcarnitine, amino acids, electrolytes, liver function test, growth hormone. Minimum blood volume 5 ml. Tubes required. 3x 0.5 ml fluoride oxalate. 3x 0.5 ml lithium heparin. 2x 0.5 ml serum gel tube. Newborn screening test, Guthrie, card, send air dried and in envelope, not in a plastic specimen bag. All tests must go immediately to the laboratory on an ice pillow. Urine. First voided urine after hypoglycemic episode, requesting glucose, ketones, reducing substances, and amino and organic acids. Treatment. The aim of treatment is to return BGL to within the normal range, and GT 3.9 mol/L, through normal nutritional intake. See flow chart. Severe symptomatic hypoglycemia should be corrected within 4-10% dextrose bolus 2 ml/kg or IM glucagon. Neonate, glucagon 0.03 to 0.1 mg/kg, and LT25 kg give 1/2 vial, 0.5 units, and LT25 kg give 1/2 vial, 0.5 units, and GT25 kg give full vial, 1.0 units. BGL should return to the normal range within 10 to 15 minutes and remain so for 1 hour. Ideally, the child should start to feed and BGL should be rechecked within 30 minutes. Persistent hypoglycemia, consider consultation with endocrinology and/or metabolic specialist. Discharge requirements. A cause for hypoglycemia. Be known, must be known, or accelerated starvation assumed, prior to discharge. Neonates, BGL greater than or equal to 2.6 for 3 consecutive normal feeds. Infants and older children, BGL and GT3 mol/L at least 4 hours post-feed/meals. Accelerated starvation. Parental education regarding prolonged starvation. Consider consultation with local pediatric team when child is not responding to first-line treatment of food, 4-10% dextrose bolus or IM glucagon. Neonates, consider transfer when Child requiring multiple dextrose boluses or dextrose infusion. Child requiring care beyond the comfort level of the hospital. Interpretation of test results. Sample. Blood. Test. Interpretation. Glucose. And LT 2.6 mol/L, hypoglycemia. Ketones. Beta-hydroxybutyrate. Downward arrow in. Fatty acid oxidation defect. Hyperinsulinemia. Lactate. Upward arrow in. Metabolic liver disease. Glycogen storage sepsis. Prolonged convulsion. Free fatty acids. Fatty acid oxidation defect. Carnitine/acylcarnitine. Fatty acid oxidation defect. Ammonia. Upward arrow in. Organic acidemias. Tyrosinemia. Liver dysfunction. Hyperinsulinism, hyperammonemia syndrome. Cortisol. Downward arrow in. Hypoadrenalism. Hypopituitarism. ACTH deficiency. Insulin and C-peptide. Any detectable insulin in the presence of a BGL and LT 2.6 mol/L is inappropriate. Growth hormone. Downward arrow in. GH deficiency. Panhypopituitarism. Amino acids. Amino acid disorders. Electrolytes. Adrenal disorders. Liver function tests. Sepsis. Liver disease. Metabolic defects. Urine. Glucose. Ketones. Downward arrow in. Fatty acid oxidation defect. Hyperinsulinemia. Reducing substances. Galactosemia. Fructosemia. Glucagon IM or S/C. Neonate, glucagon 0.03-0.1 mg/kg, max 1 mg, and LT 25 kg, give 0.5 mg, 1/2 vial/0.5 ml. Greater than or equal to 25 kg, give 1 mg, 1 vial/1 ml. Reconstitute the full 1 mg vial in 1 ml of H2O and then use an insulin syringe to draw up to the 1 unit mark on the insulin. Syringe equals 10 mg of reconstituted glucagon solution. Hashtag some infants of diabetic mothers may require up to 0.3 mg per kilogram to a maximum dose of 1 mg.